Добрий вечір всім, хто нас дивиться. Добрий вечір, Йорг. Добрий вечір, Антоніо. Покажіть мені, що ви мене чуєте. Йорг, бачу, що мене чує. А Антоніо, чи ви мене чуєте? Добре. Сподіваюсь, що всі нас чують і що всі потихеньку приєднуються на наш Zoom. І я хочу попросити Йорга представити нашого сьогоднішнього спікера, а потім вже зроблю декілька адміністративних таких ще об'яв.
Thank you very much, Dr. Bulavinova, and I'm very, very pleased to introduce to you Professor Antonio Persico. He was one of the most remarkable keynote speakers of our recent ESCAP Congress, and just after his lecture I asked him whether he would be willing to serve as one of the speakers of our webinar series, and he immediately said yes. He didn't hesitate a second. He is a psychiatrist and full professor of child and adolescent psychiatry and neuropsychiatry. In Italy it's still the combined neuropsychiatry at the University of Modena and Reggio Emilia in Italy. He studied the genetics and neurobiology of drug addiction, schizophrenia, and panic disorder, and finally he focused over the last 25 years on autism spectrum disorders. He has published so many articles, I think more than 200 articles, and he has a very high Hirsch citation index, and his research aims at identifying biomarkers and subgrouping autism spectrum disorders, studying gene and environment interactions. But he is a very well-known colleague of ours. He got the Casarelli Prize by the National Academy of Sciences in the USA in 2007. He is appointed fellow by the International Society for Autism Research in 2024. But what is most important for this evening, he has seen so many children and families with complicated autistic disorders. And he has so much experience in the practical treatment, in the medical treatment, how to medicate these kids, that I'm really very, very glad that he was willing to present this evening. I hand over to Dr. Bulavinova for some technical details, Katja, and then the floor is yours, Antonio.
Нас вже 184 людини на Zoom, і ще люди приєднуються через YouTube і Facebook. Одразу скажу для тих, хто буде питати, чи буде запис. Так, запис буде в YouTube, він вже буде сьогодні з перекладом одразу після кінця цього ефіру, бо люди будуть дивитись його в тому числі не тільки в Zoom, а в YouTube. І також буде запис в оригіналі ті, хто будуть дивитись англійською. Нагадую всім, що у нас є ціла папочка з усіма ефірами, які ви можете передивлятися. Ми бачимо по статистиці, що ви їх передивляєтесь. І скажу вам таку річ, яку навіть Йорг ще не знає, але ми йому потім пришлемо такий детальний аналіз. Але ми проаналізували наші дані за 24-й рік з вересня місяця, коли ми почали цей проєкт завдяки Йоргу Фегерту, пані Оксані Збітнєвій і пані Ірині Микичак, до кінця 25-го року. Тобто це 1 рік і там 3,5 місяці. І за весь цей час в нас більше 10,5 тисяч унікальних клієнтів, які дивились ці ефіри. Для мене це дуже-дуже дивно. Ми потім повну статистику покажемо Йоргу і вирішимо, що робити з цим аналізом і статистикою. Але ми, якщо чесно, вважали своїм успіхом на початку цього проєкту, якщо нас подивиться 60 людей, бо стільки на той момент було дитячих психіатрів в Україні. І ми думали, ну, якщо вони прийдуть і їх буде 60, то це буде дуже успішний проєкт. Наразі в нас є 10,5 тисяч, і це ми ще не рахували 26 рік. І підкреслюю ще раз, це унікальних клієнтів. А якщо ми рахуємо ще з повторами, хто серію дивився, то там буде інша цифра. Тому так, записи є, ви зможете подивитись. Записи, свої питання ви, як зазвичай, лишаєте в коментарях. І ми принагідно вам передаємо привіт від пані Оксани Збітнєвої. Вона сьогодні не могла бути з нами на відкритті цього вебінару, але вона буде нас дивитись пізніше. Пані Оксана, привіт, знаю, що ви нас потім будете дивитись. Тому, будь ласка, ми віддаємо слово спікеру, він виступає, потім я буду задавати ваші питання із чатика. Так, все як завжди. Все, всім бажаємо гарної лекції.
Thank you very much. Thank you, thank you, Katya. I would really like to express my gratitude to the European Society for Child and Adolescent Psychiatry, to Yunisef Ukraine, and to the entire organizing staff and committee for this great opportunity to be with you tonight. The topic that has been given to me is the psychopharmacotherapy of autism spectrum disorder, which is pretty dense to discuss in 1 hour. So I will move immediately into my talk and then leave, hopefully, room for your questions as they come at the end. The pharmacotherapy of autism spectrum disorder is a complex issue. Whenever we have to discuss psychoactive drugs, I think it's appropriate that we always start with our own conflict of interest declaration, which in my case is very limited. I've done very limited work with companies. Most of my work has always been supported by public funding. Let me first give you a brief outlook on this summary, on this lecture. First of all, we will give you a broader framework for the pharmacotherapy of ASD. Then we will move to the specifics of specific drugs, specific behavioral symptoms, specific issues. And finally, I want to touch on briefly on those clinical situations which sometimes are treated with psychoactive drugs, but that should not be treated with psychoactive drugs because simply do not respond to psychoactive drugs. And we need to be aware of those. Let me first start from the broader framework. Sometimes it's not easy to prescribe psychoactive drugs to children, especially to small children, to young children. Sometimes we encounter difficulties in prescribing these drugs and having family accept these treatments. So I think, first of all, it is important that from an ethical standpoint, we understand, first of all, we as doctors, as clinicians, why we need to treat some children with psychopharmacotherapy. And this is true for children, adolescents, adults. We all know that, generally speaking, autism spectrum disorder is characterized by deficits in social cognition, but at the same time by a variety of behavioral problems. Why should some patients, some individuals with ASD be treated pharmacologically? Well, since this is a neurodevelopmental disorder, we need to be aware and to be able to explain to parents that a neurodevelopmental disorder must be defined based on abnormal connectivity between brain regions. It's a simple concept, but it's critical. If there is abnormal connectivity between brain regions, and connectivity means neurons, and neurons release neurotransmitters, there is unbalanced neurotransmission in critical regions. So what we are truly doing is counteracting disruptive behaviors by trying to rebalance neurotransmission in those brain regions. Sometimes I have parents that come to me and tell me, I don't want my son, my daughter, to become addicted, to become dependent on drugs. And I tell them the issue is not that of being dependent on drugs. The issue is that until we treat these disruptive behaviors, you don't really know who your son is. What you're seeing is somebody that is like a caricature, is not your son or your daughter. We first need to rebalance things in his brain, in her brain, and then you and I will discover your son and your daughter really is. So this is an initial argument that I want to provide to you, which may help understand parents why some children do need to receive a psychopharmacological treatment. And in fact, since already the early 2000s, it was known that in the brain of autistic individuals, there is reduced connectivity between distant brain regions. So there is a reduced capacity to put together different sensory channels, to integrate different sensory informations. There is reduced capacity to translate sensory integration into movement, and there is reduced visuomotor coordination. And of course, this reduced connectivity also explains why individuals with autism have so much trouble with social cognition, with recognizing facial expressions, tone of voice, the meaning of other people's actions. However, remember that later, in these past 10 years maybe, also the role of increased connectivity has become evident, so that you can see here that there are different, very different subtypes of autism. You have autistic individuals that have reduced connectivity, subtype number 3. These people will need very low doses of drugs because they have reduced synaptic numbers. They have much fewer synapses than they should have in many circuits. On the opposite end, you have subtype number 1, where you have an excess of synapses. So it's an incredible variety between individuals, variety in terms of neuroanatomy, neurochemistry. And this is what we are trying to face when we prescribe a psychopharmacological treatment. So it is important to have this broader framework. Another issue which pertains to all neurodevelopmental disorders is that neurodevelopment is ignorant. Neurodevelopment does not know the DSM-5. Neurodevelopment does not respect the DSM-5. So very often we will have what we call comorbidities, which in reality is really a mixture of different functions displaying reduced activity or an excess in different children. So comorbidities are really the rule, not the exception. This is a very schematic summary of the major comorbidities with ASD. And, you know, I mean, it always varies also on how you define these. For example, you've heard last year from Sven that intellectual disability used to be recognized in 65% of individuals with autism spectrum disorder, and now it's down to 25%. But that's simply because our own way to recognize autism spectrum disorder has somewhat changed. There is a lot more recognition nowadays of high-functioning, verbal individuals with autism spectrum disorder. But in most services, in my service, certainly, we actually do receive, I have to say, the worst patients possible, the ones who are most critical. So this percentage is even higher. And I'm sure that for some of you, the percentage will be higher. But we should not be surprised at these comorbidities, because they are really the rule. And I'm very happy that with DSM-5, the comorbidity with ADHD has been recognized there, because that is one that makes a difference both in terms of pharmacology and of behavioral intervention. Pharmacological treatments cannot directly target autistic symptoms, the core symptoms of autism, the social deficits, the behavioral symptoms, the cognitive rigidity, the repetitiveness, which is intrinsic to autism spectrum disorder. However, there are many comorbid symptoms which can be improved by psychopharmacological treatment. And these comorbid symptoms are really the ones that oftentimes, in many patients, really reduce their possibility of going to school, of being inserted in a social context, of interacting with peers. They really are the target symptoms that you see here, are oftentimes the one that make the life of families most miserable. So aggressiveness, irritability, self-injurious behavior, hyperactivity, impulsivity, psychomotor agitation, particularly intense stereotypic behaviors, sleep disorders, and seizures are really some of the symptoms that can have the greatest impact on the quality of life of patients and families. Many of the things that I'm going to tell you today, in terms of evidence-based psychopharmacology, you will be able to find in these two articles, which are to this date the most complete systematic review of the psychopharmacology of autism spectrum disorder existing to date. The first part one, we are now in the process of updating, but I can tell you that the updates do not really change the core message of this part one. And I encourage you to look at it and also to look at the supplementary material, because the supplementary material that you can download describes case reports, describes open studies, retrospective chart reviews, and prospective cohort studies. So this is a very complete assessment. Many of the things I'm going to say are coming from these two articles. And still looking at the broader picture, we have to be aware that what is evidence-based today in the psychopharmacology of autism spectrum disorder is somewhat limited, especially when we are talking about children. The reason why it's somewhat limited is because there are relatively few randomized control trials with placebo, double-blind, relatively few, and most of them, you can see here, most of them are of short duration. So what we can say in terms of evidence-based medicine, I will try to tell you all the time what is evidence-based, has to be complemented also oftentimes, but what is based on personal clinical experience, because evidence-based medicine in the psychopharmacology of autism is limited. When I am going to be telling you things based on my own experience, I will honestly be telling you this is not evidence-based. It does not come from randomized control trials. It comes from my own personal experience. Another problem with the psychopharmacology of autism spectrum disorder, especially in children, is that we are forced more often than not to prescribe off-label. Off-label meaning that there are very few drugs that have been approved, officially approved under a certain age for specific indications. But more often than not, based on the literature, based on the science, and based on our own experience, we are forced to intervene because sometimes it's an ethical issue to relieve patients and families from very disruptive behaviors. Let me conclude this first part with two pieces of practical advice. These come from my own experience, but I am starting off from this because this, I think, is probably some of the most important take-home message that I want to give you today. Individuals with autism, individuals with intellectual disability, especially individuals with low-functioning autism, are very hypersensitive to psychoactive drugs. So, my advice is to start low and stay low with your dosage, because if you apply automatically to these patients the same dosing that you're accustomed to using in patients with schizophrenia, in patients with bipolar disorder, or with major depression, you will notice that more often than not, from the very start of treatment, you will have major side effects and run into a lot of problems with the compliance of families. So my advice is to start with a dose of about 1/4 of the starting dose recommended for other disorders. The reason for this is the following. I have shown you here, I'm showing you here in this cartoon. We are used in child psychiatry and in psychiatry to start with a given dose and then to progressively raise the dosage. Because there is an initial time when, as we are raising the dosage, there is no benefit. Then we reach the minimum effective dose, and that's where we begin seeing therapeutic effects and maybe a few side effects which are tolerable. As we increase the dose in order to increase our therapeutic effects, we reach a maximum tolerable dose because then side effects become intolerable. This is what we're used to see in psychiatry. However, very oftentimes when you are treating an individual with autism, whether he is a child, an adolescent, or an adult, you will notice that the minimum effective dose that you're used to use in other disorders is already in this red area. It's already giving you very serious side effects. So this is why I'm advising you to please start with a dose which is about 1/4, and then you will have time to increase the dose if necessary. And more often than not, you will notice that already that low dose will be sufficient to give you exactly the therapeutic effect that you were searching for. In the United Kingdom, this is taken from the NHS, the National Health System in the United Kingdom. You will notice that even there, if you have an intellectual disability, protocols for rapid tranquilization call for using a lower dose than if you do not have an intellectual disability. So this is just an example I'm making to you to show to you that intellectual disability, autism spectrum disorder, oftentimes come with an increased sensitivity to psychoactive drugs. The second point is that in choosing which drug to prescribe, there is no other disorder like autism where you need to take into account the formulations that are available in your country. Many children with autism have difficulty swallowing pills, so you're forced to prescribe based on the existence of a liquid formula. In other cases, you will have autistic children who have sensory hypersensitivity and olfactory hypersensitivity. which will make it impossible for them to take the liquid formulations. I've had incredible stories, children that were able to sense with their olfaction, they were able to sense 2 drops of risperidone in a bottle of Coke and would not drink it. So this is simply to say that there are choices that we make that are not always compatible with the perfect science of randomized controlled trials. But in practical life, we have to take these 2 issues into account. This was just to give you an initial broader framework. Let's now move into the specifics. Why should we start with sleep disorders? We should start with sleep disorders because they are frequent, very frequent. In our own sample, which is now very large, 50% of patients, be it children, adolescents, or adults, come in with sleep disorders. Typically, it's difficulty falling asleep, frequent night awakenings, or both. There are multiple reasons why it's perfectly understandable that in autism spectrum disorder, you will have an abnormal circadian rhythm. So it is not surprising. But once you have a sleep disorder, the life of the families is miserable, the life of the patient is miserable, and what is worse, the following day, the child will be more hyperactive, more self-aggressive, or more aggressive, and will have more emotional dysregulation than if he or she has had a good night of sleep. So it is important to treat sleep before we treat aggressiveness. I always tell my residents, do not start a psychoactive treatment unless you're in an emergency room if you have a child that has sleep disorder and constipation. You first treat the sleep disorder and the constipation, and then after 1 month, you prescribe risperidone if that's still necessary. But oftentimes you will notice that children will already be a lot better. As you know, melatonin is first-line treatment, but let me say that there is a lot of confusion around on how to use melatonin. And so let me go briefly with you over the fact that melatonin, if it's immediate release melatonin, lasts only for 2 or 3 hours. So you give it at 9 o'clock, it's going to be gone by midnight. Melatonin serves for falling asleep, initial insomnia. If you have a midnight awakening, melatonin usually is not helpful. The only time when immediate release melatonin should be given at an early hour, like 6 p.m. or 7 p.m., is when you want to anticipate the circadian cycle. When you have autistic children that fall asleep at 2 o'clock in the morning and that sleep until midday, in that case, it is appropriate to administer melatonin at this time and anticipate the circadian cycle. Otherwise, the rule is the child gets melatonin once he or she is already in her pajama, and melatonin starts acting within 15 minutes, and it takes care of falling asleep. If you have a problem with midnight awakenings, you need to use extended release melatonin. Extended release melatonin will work usually for about 7 hours or even more. This is what is going to be active on frequent night awakenings. However, extended release melatonin must come necessarily with small pills. And what happens if the child is very small, very young child, and he spits pills? One strategy that you can try is 5-hydroxytryptophan. 5-hydroxytryptophan passes the blood-brain barrier, gets into the brain, and is used by the brain to synthesize melatonin. typically the peak synthesis of melatonin will be 6 hours after 5-hydroxytryptophan is administered. So if you give 5-hydroxytryptophan during dinner time, you can pretty much calculate when the peak of melatonin synthesis will be. It will be 6 hours after. And that's effective, especially, I have to say, in young children, in preschoolers, very effective in preschoolers. As children age, it becomes less effective. And in my experience, it really does not help much in adults. Unfortunately, it is in adults that we have the greatest number of individuals who develop sleep disorders. We tend to think of children, but in reality, it is adolescents and adults that as they age, they develop more sleep disorders. So, briefly, this is physiological melatonin synthesis by the brain. If you give immediate release melatonin, this is what you're doing. If you give extended release melatonin, you're pretty much mimicking the physiological peak of melatonin at 3 o'clock in the morning. If you're giving 5-hydroxytryptophan, you have to give it earlier, dinner time, as if it was a food, and it's going to give you this type of response. And here you have the summary of all drugs that can work, can help with sleep. If melatonin is not sufficient, and by the way, you can easily go up to 3 milligrams. Sometimes I go up to 5. I have to say that some colleagues go up to 10. When I need to go up to 10 because 5 milligrams of melatonin will not put the child to sleep, I usually move to one of these second choices drugs, especially pyrizine or quetiapine, sometimes clonazepam or clonidine. Depends on what is available in your country. And this ensures a good night of sleep. And trust me, this is preliminary to any other improvement. If there is not a good night of sleep, I don't want to say that you're wasting your time prescribing other drugs, but their response will definitely be limited. Second issue, why treat chronic constipation? Gastrointestinal problems are frequent in autism spectrum disorder, and among the ones that you will encounter, chronic constipation is the most frequent. Now, you have to consider that treating chronic constipation is not simply because the child has maybe pain or discomfort due to constipation. It is because due to increased time in the intestine, there is an increased absorption of substances that go to the brain and increase behavioral problems. This is a very long topic and I won't get into it, but we don't simply absorb proteins, minerals, and vitamins. We also absorb substances produced by the gut flora, by bacteria, that do have consequences on our brain functioning. Some of those are not helpful. And this is just to show you that 1 month after mobilizing the gut simply with macrogol, so these are chronically constipated children where we mobilize the gut with macrogol, 1 month and 6 months afterwards, you can see that there is a significant decrease in many different autism symptomatology. There is an increase and improvement in imitation, a general improvement, even in autistic symptoms and in fear and anxiety. So it doesn't take much to mobilize the gut using macrogol. It really doesn't take much. In general, I strongly advise to treat the first month constipation with macrogol. If you have chronic diarrhea, that may respond to probiotics. But if you have chronic constipation, don't waste time. Go to with Macrodol. And to treat sleep disorders. And then to have the child come back to you 1 month later, look at him again, look at her again, and if you still think that there is a problem with aggressiveness, with irritability, and with self-injurious behavior, despite the fact that sleep is under control and the gut is under control, then perfectly fine that you proceed with these other treatments. Of course, aggressiveness is more typical of adolescents and young adults, but this is very subjective. It can occur at any time, and oftentimes it is more present in nonverbal, cognitively disabled, autistic individuals, in individuals who are lower functioning. One important point is that if this is what you have in terms of aggressiveness to others, when you do not have verbal adolescents, nonverbal adolescents will be more frequently characterized by self-aggressive behavior because they will be frustrated with not being able to express their needs. We will go back to these in the last section. Some of the drugs that are most effective on aggressiveness, irritability, and self-injurious behavior are second-generation antipsychotics, risperidone, aripiprazole, to some extent olanzapine. And if you need a drug that does not have any smell at all, so you can bypass any kind of olfactory hypersensitivity, or for some reason you cannot give risperidone or aripiprazole, then haloperidol should be considered. It's first generation, but it's still quite effective. The reason why I'm highlighting hyperprolactinemia here is to remind me to mention to you that if you're prescribing risperidone, if the response of the child is excellent, but if the child has elevated prolactin blood levels, that is never a reason to stop risperidone. All you need to do is to pair risperidone with a small dose, 1-2 milligrams of aripiprazole, and you will see the prolactin levels go down to normal. So never stop risperidone because you have elevated prolactin levels. Simply associate aripiprazole 1-3 milligrams at the most, and you will see prolactin going down to normal. How do we choose? Well, usually it depends. I mean, there are different criteria. Of course, one of them is the side effects. Risperidone leads to more prominent and more immediate weight gain. Aripiprazole also increases weight, but it takes longer time. Aripiprazole is somewhat less effective, slightly less effective, so it depends on what you need to do. Among other drugs, one that I advise you to use when you need to improve sleep disorders and also maybe raise affective status, counteract depression, you can use quetiapine. A small dose of quetiapine, like 25 milligrams at night, given only at night, may be helpful. But we need to remember that many of these drugs don't work, at least not as a single treatment, like lurazidone in single treatment. There is no evidence of efficacy. And these other second-generation antipsychotics, there is no double-blind randomized control trial. And as you will be able to see in this paper, the evidence of their use, published evidence of their use, is limited. Other drugs are oftentimes used to counteract aggressiveness, irritability, and self-injurious behavior. However, they need to be used with caution and targeted. There needs to be targeted use. Why? For example, methylphenidate and psychostimulants can be very effective, but they can be very effective only if there is a true, real comorbidity with ADHD. Sodium valproate. If you have a child that is irritable because he is low with his affective status, with sodium valproate, he's actually going to get worse. If you have a child who is slightly bipolar and he's down with depression, sodium valproate will not help. Lamotrigine will help, not sodium valproate. So essentially, mood stabilizers, psychostimulants can be useful, but it depends on the specific case. Clonidine and guanfacine are two excellent drugs, excellent. You can use them also to improve sleep. There is a lot to say about these drugs. I don't have time to get into details. If you have them in your market and if you're interested in knowing more, please ask questions. Naltrexone has been used very early on in the 80s and 90s, one of the first drugs to be prescribed. It has a modest effect. In my experience, it goes to about 20-30%. So it may be helpful, but it doesn't work miracles. We already said about risperidone. I don't want to waste time with these. And one good news is that risperidone maintains its efficacy over time. If you have risperidone that loses efficacy, you have to worry about either having to increase the dose because the child is grown up, or maybe a new comorbidity arising, for example, the onset of a bipolar disorder. But typically, on aggressiveness, irritability, etc., risperidone maintains its effectiveness over time. So does aripiprazole, which is pretty much as effective as risperidone, but I have to tell you that there are cases where risperidone will still maintain a greater efficacy. And in fact, you can see in this decrease in ABC irritability scores that risperidone reaches this level, whereas we've seen before that risperidone goes a little bit beyond. So aripiprazole is an excellent choice, but still it may need to be enforced with other drugs. I will leave these to the slides, but these are just some of the three most common mistakes I see, at least in my country. Polypharmacotherapy, putting together multiple drugs, which sometimes are paired in not the best and most appropriate way. Starting treatment with doses too high for ASD, we already said that. And administer antipsychotics at a time during the day, which is not the best in terms of their pharmacokinetics. Some people use risperidone only at night. In general, I've seen that sometimes produce irritability the morning after. So my suggestion would be to use quetiapine at night if you need to have the child sleep, but then to use risperidone always twice, morning and evening, because risperidone has a very high affinity on D2 dopamine receptors, and that may produce problems in terms of tics, in terms of hyperactivity, in terms of other type of consequences. I won't get into these, but this is simply to remind you, please do not associate antipsychotics which have similar pharmacological profiles. Makes sense to associate risperidone and lurasidone, for example, but it does not make sense to associate olanzapine with clozapine. That's self-evident. These we already said. Please use low doses. Do not overdose. And remember, many of the patients that you will be treating may be genetic syndromes that have never been diagnosed genetically. If that is the case, second-generation antipsychotics may produce catatonia. So if you see things go worse, if you see things get worse, please remember that there is a possibility that you may be triggering catatonia with these drugs. in cases where you have low-functioning individuals who are carrying certain genetic syndromes that have not been diagnosed. Hyperactivity and impulsivity do respond well to methylphenidate and to psychostimulants. So I very much encourage you, once you have started a treatment, for example, with risperidone, and you see that there is a good response in terms of aggressiveness, but the child is still very, very hyperactive, to associate methylphenidate to risperidone. You will likely have a very good response. However, we must consider that in autism spectrum disorder, the treatment of ADHD will yield dropouts more frequently than in children that only have ADHD but not autism, because there may be a greater number of children who will undergo side effects. However, if you're careful with the diagnosis, you will usually be able to avoid insomnia because you will avoid giving it late, and you will also avoid treating bipolar children with methylphenidate. That would not be a good idea. Paradoxical aggressiveness, you will usually be able to tell, and you will increase the dose of risperidone without having any problem with methylphenidate later. So paradoxical aggressiveness is usually typical of low-functioning individuals that receive methylphenidate without having received prior to methylphenidate some kind of treatment for aggressiveness. Very useful clonidine and guanfacine. In my hands, I have to say, atomoxetine has never been very effective and has always given a lot of side effects, but that's my own experience. There are some randomized controlled trials that support the efficacy of atomoxetine in ADHD comorbid with autism spectrum disorder. Repetitive behaviors. Now, repetitive behaviors are really an intrinsic part of autism spectrum disorder. They are part of criterion B, stereotypic behaviors. However, here we are talking about the most severe forms of stereotypic behaviors, which really make it impossible sometimes to do anything with the child in terms of rehabilitation of a behavioral intervention. The literature here is not enthusiastic about any single treatment. I am not enthusiastic about any single treatment. Some children improve with risperidone, but most do not. Some children may improve with a low dose or a higher dose of fluoxetine, but many do not bear with fluoxetine because they go toward, they develop agitation, they become aggressive. Some children respond to valproate, but many do not. Some children respond to a low dose of buspirone paired with behavioral therapy. But buspirone in some countries is difficult to prescribe because at higher doses gives weight loss. So it's been abused by anorexic girls, by anorexic patients. It's been abused for weight loss. So this chapter, repetitive behaviors, are really the ones where I have less support to give you. I have to tell you, try and see, because there is really no strong evidence that any single specific drug will be helpful. And here you see, for example, the lack of efficacy of citalopram and SSRI in repetitive behaviors and OCD symptoms, obsessive compulsive symptoms in autism spectrum disorder. Epilepsy. I don't have much to say about epilepsy because there is nothing really special about the treatment of epilepsy in autism spectrum disorder as compared to the treatment of epilepsy in idiopathic epileptic children. One thing we need to consider, however, is that 70% of autistic children that develop epilepsy will do so as preschoolers, 1 to 5 years of age. 20% will develop it during adolescence, but there is even 10% of autistic individuals who will have their first seizure as adults. You will rush them to get an MRI, brain scan, because you fear they may have a tumor or something like that, and there is nothing at all. It's just a very late onset form of epilepsy. Seizures can occur in up to 30% of all patients with autism spectrum disorder, especially in low-functioning individuals, in females, in nonverbal individuals. And you always wonder if they have developed seizures because they have a more severe neurodevelopmental problems, or if they have been diagnosed with autism, but their form of autism is more severe because they also have this comorbidity with the seizures, and the seizures are making the autism more severe. They impact with lower response to treatments. Furthermore, EEG abnormalities are present in another 35% of autistic patients who will never develop a seizure. And we can talk about this during the discussion if you're interested. In general, epilepsy in ASD has no specific features in terms of treatment. So the treatment is usual, and there is nothing special about the treatment that we prescribe for autistic individuals with epilepsy. One last point is the so-called paradoxical effect. Paradoxical effect is more typical of the administration of benzodiazepines. So you give a benzodiazepine, and instead of seeing the child, the adolescent, the adult become less anxious or quieting down, you will see that child becoming much more hyperactive, much more aggressive, much more impulsive. This is what we call paradoxical effect. Now remember that the paradoxical effect must, if it's real paradoxical effect, must occur very early on, immediately. It's not something that shows up 1 day or 2 days after. Why? Because it's due to an inverted transmembrane gradient of chloride, such that benzodiazepines that typically will produce a hyperpolarization, they will tend to decrease the number of action potentials in neurons, will actually have the opposite effect. They will depolarize neurons. Because if in a normal brain, in a normal neuron, when I open GABA A receptors, chloride gets in and the neuron becomes hyperpolarized, the membrane potential goes down, it becomes more negative. So these neurons becomes inhibited. If I have more chloride inside the cell, when I open these channels, chloride will leak out. And as chloride leaks out, negative charges will produce an activation of the cell. So the cell will depolarize and the child will become more excited. Why does this happen? Because this type of balance here is due to these molecules that essentially decide how much chloride will be inside and outside the neuron. This pattern here is present in the prenatal life and in very early postnatal. This pattern is present, the right one, in mature neurons, in mature circuits. However, the immature form can remain in the brain when, especially when there are modest malformation, modest structural abnormalities, small, which most of the times you will not be able to see with a brain MRI, but that have been documented in the brain of autistic individuals in postmortem brains, anatomically. So around these crater, around this malformation, neurons will have this conformation here, not this one. So it is fairly frequent that you will have an activation when you give benzodiazepines rather than having the child quieting down. However, it's by no means a set rule. So not only it's not forbidden to prescribe benzodiazepines, but I encourage you, if you have a child, an adolescent or an adult that has major anxiety problems, once or twice test them, give them the benzodiazepine, give a benzodiazepine that is short acting, and possibly, if you can, have them come to your office. You give them the benzodiazepine and you observe the person at intervals during the first 2-3 hours. If that's possible, you will be able to observe whether the effect is sedating or whether the effect is activating. And I tell you that because not always are families reliable in their report. If the effect is positive, I strongly encourage you to use benzodiazepines, but not on a daily basis. On a need basis, meaning once, twice a week, when the family knows that the child is going to be exposed to a situation that will increase his anxiety. Because used on a permanent basis, on a daily basis, I've always seen benzodiazepines ultimately produce activation. So they lose their effect. If they are used once or twice a day or once or twice a week, they maintain their efficacy. And of course, if you have a paradoxical effect, simply don't use them. Finally, there is a set of compounds that have suggestive evidence of efficacy. Some of these are nutrients, so they can be prescribed not by doctors, but even just found in the pharmacy. And some of them are drugs like N-acetylcysteine. And I encourage you, when you have a partial response with the usual psychoactive drugs, to keep these in mind and to use them. In particular, as far as the evidence is concerned, here you have the number of RCTs, the randomized controlled trials, and you can find the evidence in this article. As far as my experience is concerned, my experience has been very good with N-acetylcysteine, provided it's given at a high dose. I usually use it at 1,800 milligrams a day, 600 milligrams 3 times a day. If you use at that dose, it is helpful, very helpful in increasing the efficacy, for example, of risperidone. If you have a partial response to risperidone and the child is gaining weight and you don't want to increase further the dose of risperidone, you can add N-acetylcysteine, and it's especially effective when you have situations with children that get often sick with cold, with sore throat, often sick, that activates neuroinflammation. And N-acetylcysteine is helpful. And if you use it for 1 month and it doesn't work, you can always stop. Another compound which is helpful is coenzyme Q10, L-carnitine. These are compounds that sometimes also display a very nice antidepressant effect. Of course, I'm talking about mild to moderate depression, but they do improve the metabolic state of the child, and they are helpful. Sulforaphane, I'm not experienced myself, but that's essentially because it's not easy to find in my country, but especially because I'm told from colleagues in the United States that it smells and tastes a little weird, and that children with autism oftentimes don't like it, but it is effective apparently on irritability. And when you have children that you must treat with a second generation antipsychotic, and that you fear that may be gaining weight, and they're already a little chubby, you can start metformin. And metformin reduces weight gain when associated with the typical antipsychotics. And then finally, please help families understand that not everything that is out there in one article is effective, and not everything that is on the internet is effective. There is a lot of people that are selling products on the internet that are absolutely not effective and sometimes even damaging. One clear example of this is secretin. There was a time 20 years ago when secretin was the real bomb, was the real news, was the hope for the autism field. 16 studies have proven secretin not effective. So this is just to say, help people see that they should not rush to any gold mine that is publicized on the web. Finally, last 5 to 10 minutes to say that there are situations when, if you try to treat aggressiveness with psychoactive drugs, you will fail. These situations need to be diagnosed, understood, and changed without prescribing psychoactive drugs. This is the list of the most important situations. Some of them are fairly obvious. Physical pain. This is the list of the things that can happen that will suddenly transform a relatively quiet and collaborative child with autism into a relentless little devil that you cannot stop, and parents will be absolutely crazy. Always start from wondering whether there is not something wrong at the physical level. Infections, kidney stones, cavities in the teeth, very frequent ear infections, very, very frequent. And all you need to do is check. And sometimes I've had the luck to diagnose an ear infection just by seeing the child walk into my office with his head tilted to the side. You know, they don't speak, they're nonverbal, they don't have a body scheme, so that they cannot tell you that it's hurting, but you need to think about it, get a rush, quick blood cell count, look at the ears, and this is the list that I give to parents to make sure that they are ready for that day, because one day is going to come and it's going to be an emergency, and that day they need to be ready and know what to do together with their pediatrician. Secondly, we already saw this. If the adolescent, especially the adolescent, is frustrated because he or she cannot communicate to his parents his needs, he will become aggressive. So please make sure that no child reaches age 8, because some of you may be surprised, but age 8 is when the very first hormones start showing up, knocking on the door of the brain, and start changing the brain. So between 8 and 9 is typically when children become more hyperactive, more aggressive, more stereotypic. So if this is not in place, if augmentative and alternative communication is not in place by age 8, we are in trouble. So please make sure that, if possible, if it is available in the area, that a speech therapist starts working with the child with images or with sign language already not later than 3.5 years. Because if then the child will develop language, we are all very happy. But if not, you will have a channel of communication. And the most difficult part here is to make sure that also parents use the same channel of communications, because parents oftentimes will not. I don't have time to get into this, but I will leave you the slides. Sensory information processing. I will leave you this slide. I think it is emotionally touching to see people with autism that cannot speak but can write explain to you how they feel, why they bang their head against the wall, because they don't have proprioception. Some of them don't have proprioception and don't feel the position of their hand and arm unless they bang it against the wall. Now you understand that if that's the problem, risperidone is not going to help. If anything, it's going to make things worse. This scheme is a hyper simplification. Do not believe this is the way it is. It is an oversimplification. The real problem is really that there is difficulty in integrating information from different sources. So if a child is present in a very large environment, in a big environment, like a supermarket, then that's going to be ideal to activate, to generate a temper tantrum through this mechanism. Reduce discrimination precision, abnormal somatotopic representation, inconsistent perceptions. The world of an autistic individual is never the same, even if stimuli are the same. So in summary, if this is what parents tell you, and these are sentences taken from my own clinical practice, the treatment is not risperidone. The treatment is telling patients, before entering the supermarket, put cuffs on your child, put earplugs, and then make sure that when you leave the supermarket, you take them out, take them off. If a child becomes aggressive in tunnels, when he gets out of tunnels, it's not probably any kind of aggressiveness, it's due to light hypersensitivity. This is the treatment. It's non-pharmacological and very effective. If a child is dependent on smartphones, and autistic children become dependent on smartphone, on tablets, on computers very rapidly, because smartphones are very nice, and because we adults are dependent on smartphones. Imagine a child. Then when you go and say, now it's dinner time, and take out from the child your smartphone, the response is going to be dramatic, because that's a sign of withdrawal dysphoria. It's a sign of dependence. It's not problem behavior. So these will not respond to risperidone. It will need detoxification from smartphones, which will take on average about 1 week to 2 weeks at the most. And then the child will not be compulsive about them. You need during those 2 weeks to substitute the smartphone with other fun activities, and trust me, the child will survive. If anything, the problem will be parents who will not be able to use their smartphone in front of the child. But please do not prescribe risperidone to children who have smartphone dependence, because it's not going to work. And finally, when you have adolescents, remember that no matter how compromised, no matter how intellectually disabled, no matter how nonverbal, adolescents require that you respect their room, their space, their business. And by the way, this is taken from the door room of my son. When he was 14, he bought this in an airport and put it on the door of his own room, and I still have it. And I've always seen that sometimes parents continue to treat their adolescent and grown-up children like they were children. They walk into their room without knocking on the door. Teach parents to knock on the door before walking into the room of a 15, 16, 20-year-old. More often than not, you will see that those crises of aggressiveness against their parents when they walk into the room will stop, because the autistic individual will know that the parent is coming, and then there won't be no problem. Concluding remarks. Pharmacological treatments are helpful, and their efficacy is documented but limited, we have to admit that. They must always be part of a broader therapeutic project. There should be, hopefully, no single individuals who is treated only with drugs, although I have to admit that there are parts in this world, parts in our country, probably in your country, where it's difficult to find behavioral therapists or rehabilitation or work programs. No drugs are directly effective on core autism symptoms, but treating comorbid symptoms is very helpful. A preliminary evaluation of medical and psychiatric comorbidities is absolutely mandatory because sometimes aggressiveness can have very different meanings. And of course, if you're bipolar, you may need lithium, you may need other drugs. Patients must be followed over time. Please don't prescribe and forget. Sometimes we prescribe and we forget, and that's not good. We need to always prescribe and tell parents, please contact me again within 1 month, 2 months, 3 months, whatever, and follow those cases because parents oftentimes undergo a painful feeling of having been left alone. The prescribing doctor must always be ready to reconsider her prescription based on the response of each specific patient. Sometimes I joke with my residents and I say that if there is one area in medicine that will teach you the Christian virtue of humility, that's the psychopharmacology of autism spectrum disorder, because you will have to admit to yourself that you have made a mistake more often than not. But through mistakes, hopefully small mistakes, we step by step improve the life of our patients. And I would like to conclude by saying that what we do, what you do in this admirable way, given the time that you are living through and the circumstances, I'm sure, is make sure that these children are taken care with the same care of this mother, because we would all like our little patients and our grown-ups to be able to walk through the trail of life on their own legs without falling. But then at the same time, we are ready to support them, to receive them whichever way they are, and to love them with all our science and with all our heart. So, thank you for your attention. And also, please let me give you my best wishes, truly. I'm acutely aware that today is the first day of your 5th year of war. There have been meetings of Ukrainian communities, gatherings, also in Modena yesterday, and I was there as well. Please accept my best wishes that there won't be another first day of another year of war. Best wishes of peace, of freedom, and of reasonable economic stability to you and to your dear ones. Thank you for your attention, and I'm available to answer your questions.
Дякуємо дуже, Антоніо, і дякуємо і за лекцію, і за такі гарні слова для нас важливі на сьогоднішній день. В нас багато питань, ми візьмемо якусь кількість, скільки встигнемо, а потім будемо розходитись, бо вже пізній час. І так, пані Оксана Мельник питає, які групи препаратів мають доказову базу щодо зменшення стереотипної поведінки при РАС?
As I said, there is no group of drug that has demonstrated efficacy. There is one randomized controlled trial of fluoxetine, but I have to tell you that I used fluoxetine, and every time I use it, my children and my adolescents become violent. They become very agitated. So in my hands, you can try, but I've never seen it help. I've had some patients improve with risperidone, but not enough, and others that improve when you put together risperidone maybe with an acetylcysteine. Others improve with buspirone, but there is no class of drugs that will be effective altogether, probably because the pathophysiology at the neurological level is different from patient to patient.
Продовження цього ж питання від пані Оксани Мельник. Чи виправдане застосування атипових антипсихотиків, наприклад, рісперидон або аріпіпразол, саме при стереотипіях без агресії?
You can try if the stereotypies are very intense and you need to decrease them in order to allow the child to go to rehabilitation or to school. You can try. Unfortunately, stereotypic behaviors tend not to respond to anything. That's the truth. In some cases, you have wonderful responses to specific drugs. You have the list in my slide, and you can try each one of those. It's the one symptom that has the least consistency in response.
Та ж сама пані Оксана Мельник питає, яку максимальну кількість часу може приймати дитина рісперидон?
If you mean how many times during the day, I typically how long a time? There is no limit. I mean, it depends on the symptoms. It depends on whether the child is achieving a better adaptation with that treatment as compared to no treatment. But I have children that have been taking risperidone for many years. I control them, EKG, heart, blood works, bring down prolactin using aripiprazole. So I make sure that they are healthy, but if they need risperidone to balance the neurotransmitters in the brain, they will need risperidone.
Пані Алла Сохацька питає, з якого дозування ламотріджину пропонуєте почати лікування біполярного розладу у підлітків?
Okay, lamotrigine is really an excellent drug, very effective when you have patients that are on the lower end of bipolar, they are depressed. I much prefer to use lamotrigine as compared to using antidepressants, because antidepressants will make patients rapidly switch when they are autistic. Lamotrigine usually will not. But you need to be careful with the dose. I suggest that you start with as low a dose as 25 milligrams divided in half in the morning and half in the evening, and then you go up to 50 and 50. I have had one autistic individual switch into mania, and that was really unpleasant when he went from 25 and 25, morning and evening, to 50 and 50. So this is just to tell you that you need to be careful with the dose, and if you're already achieving a good response with a very low dose, stay at that dose. Don't feel compelled to raise the dosage.
Пані Ольга Проніна пише, маю доньку 8 років, порушення сну немає і не було, агресії і самоагресії немає, закрепи з самого народження, жоден лікар не звертав на це уваги, дитина не розмовляє, після прийому холіну спостерігається значне покращення, після відміни – відкат. Лікар каже, не можна його приймати постійно. Питання. Чи є аналоги, які б можна було приймати в період відміни?
I'm not sure. Can you write the name of this compound? Because I'm not sure that I understand. It may be a commercial name or...
Я зараз попрошу того, хто нас зараз слухає, нашу команду написати в коментарях холін і подивитись навіть в інтернеті якийсь аналог, якщо він є. західний. А поки переходжу до наступного питання і потім повернемося до цього питання. Добре? Так, наступне поки що питання, поки команда пише. Оксана Гаїна. Хлопчик, аутизм 13 років, руйнівна поведінка, отримує оланзапін 5 мг, був респіридон аріпіризол, але раз в день дає збудження, агресія, руйнацію без причини. Що можна додати до лікування? Чи можна аміназін, чи міняти лікування?
What time during the day does that crisis occur?
Зараз почекаємо, може нам пані Оксана, якщо вона нас ще слухає, відповість. Поки ми чекаємо, переходжу до, або зараз чекайте, може є, ага, в день. Це відбувається в день.
Well, if this was my patient, I would take the time to understand what's happening, because during the daytime is too broad. Let me give you a few examples. Crises that occur frequently at 11 o'clock or at noon may be due to gastritis. Crises that occur after half an hour after lunch and dinner may be due to gastroduodenitis, and they will respond not to psychoactive drugs, they will respond to gastroenterological drugs. Does the child come back from his center at a given time during the day, and does he want something that immediately needs to be given to him? And if not, he's going to have a temper tantrums. So there are issues here that need to be addressed before we think of increasing the dosage of the drug. Okay, this is my last section, the last section of my talk. When, why, how. So we need to know more. If you want, I can deal with this by email separately on another day, but I mean, this is the idea exactly about the last section of my talk.
Від пані Світлани Огороднійчук питання. Чи допоможе безглютенова дієта дітям зраз?
Unless they have gluten sensitivity, it will not be helpful. Usually, children that improve with a gluten-free diet are children that have gut dysbiosis. But gluten-free diet, well, scientifically speaking, there is no evidence of efficacy, but in my experience, it's very rare that they help. And when they help, usually it's because there is a gut dysbiosis, and in that case, you treat the child with something that improves their intestinal functioning and with a probiotic, and you solve. You know, I mean, gluten is important. It's an important part of our diet. Children need to have amino acids to grow. And so gluten and milk-free diets are dangerous in terms of how much amino acids the child receives ultimately once you've taken out the gluten and the casein. So it has to be demonstrated there is an intolerance.
Пані Алла Ягушева питає. Дитина з РДУХ і аутоагресією приймає атомоксетин 25 мг вранці. В якій дозі і в котрій годині радите приймати рісперидон?
The hour is always going to be morning and evening. The hour is always going to be somewhere around 7, 8 o'clock in the morning and 8, 9 o'clock in the evening or something like that. It depends on when people have lunch and dinner and breakfast. The dose, I think, should start very low. When I say low, I tell you that usually people in my country start 0.25 milligrams in the morning and 0.25 milligrams in the evening. I start with less than that. I tell parents to use the liquid form and to give drops. And I start with a dose which is 2 drops in the morning and 2 drops in the evening, which is the equivalent of 1/6 of a milligram a day. You would not believe that I've started doing this because there are children that already with such a low dose have high prolactin. And there are children that start 0.25 and will have immediately major sedation, side effects. So I start low and then I raise if I need. So this is what I would do if we were here.
Так, пані Світлана Арсенюк, як допомагати дітям з аутизмом, коли їхні спогади, навіть з далекого минулого, які для них були травматичні, індивідуальне значення, переживаються в реальному часі досить інтенсивно, викликають спалахи агресії, спогади неконтрольовані, виникають спорадично і непередбачувано.
Again, this is a very difficult question because once those memories are created, it's very, very hard to contain these emotional reactions. There is some kind of work that could be done beforehand in training autistic individuals in going to a shelter, going routinely to a shelter, to the same shelter, being used to go to the shelter, so that then once they need to do so on an emergency, they're used to it. It's like routine. They may need to wear earplugs. It depends on what the shelter is like. If it's a small environment, it's better. If it's a big environment, you know, like the underground, like a metro, then that could be worse. Once those memories are created, I don't think you can get rid of them unless you consider treatments like ECT or stuff like that. But I don't think that's feasible. I would say that those memories will remain. What you need to do is to start raising single drugs and associating drugs reaching the maximum dose. And then I cannot exclude that there may be types of interventions that can be done, but it's a very difficult question to tackle. And of course, it's one where you have more experience than I do. So.
Так, буквально ще 3 питання забираємо і відпускаємо Антоніо. І так, питання від пані Ліани. Як розрізнити симптоми сенсорного перевантаження при РАС від флешбеку або дисоціативного епізоду при ПТСР?
A flashback needs to occur within an environment that in some way has at least some elements that will remind me of the trauma. A sensory overload needs a sensory input. And usually a sensory overload will require certain conditions. It may be large environments, it may be repetitive stimuli, like for example, sirens coming from different parts of the city. Not a single siren, but sirens coming from different parts of the city will likely, I can imagine, generate a sensory reaction in some children. As sensory overloads, whenever you have the very, very first initial signs, should immediately respond to blocking that sensory channel. A déjà vu will not, of course. So I would try and tease out these two situations based on where was the child when this happened, and if it's more likely that there was a sensory stimulation from multiple sources, or with a timing that is very disturbing, or whether it is going back to the same environment or being exposed to something that reminds me, maybe a few elements that remind me of the place and the time when I underwent the trauma.
Пані Остапчук Вероніка питає, коли краще призначити аріпіпразол вранці чи в обід з рисперидоном, щоб зменшити пролактин?
I haven't gotten...
Ще раз тоді. Коли краще призначити аріпіпразол вранці чи обід з рисперидоном, щоб зменшити пролактин?
Okay, aripiprazole has a very long half-life, so it is really not important what time you give it. Usually, I give it in the evening after dinner, but it doesn't really matter what time you give it because it's once a day and it's a very low dose. You will not need to give more than 3 milligrams. Usually 1 milligram, 2 milligrams is more than enough. It's a very prominent effect. You know, you have a prolactin of 64, 1 milligram, you go down to 44, 2 milliliters, you go down to 24. So it's a major effect that we're talking about, seen in most patients. And it doesn't really matter whether, I usually give it at night, but I don't think it matters. Time is more important with aripiprazole when you're using aripiprazole as single drug and when you're using higher doses.
І багато питань стосовно холіну, тобто вітаміну В4. Чи його використовують, чи ні?
Vitamin D?
Вітамін Б.
B. Okay.
B4.
Yeah. Well, I'm doing a lot of scientific research on these nutraceutical compounds because I think they should be tested with the same rigor that we use for psychoactive drugs. I have to say that, in general, the effect of all nutraceutical is within the small range being 0.2, 0.3 effect size, as compared with 0.6, 0.7 effect size of a risperidone or methylphenidate. So don't expect that level of response. There is no set rule. For example, I have now clear evidence, because I'm running myself an RCT, that vitamin B, vitamin E, and coenzyme Q10 improve significantly about 25% of autistic children. They improve slightly another 30 to 40%, but there is at least another 30 to 40% that respond not at all. So there is no set rule. And when you go to that last slide that I showed in my section 2, you know, those are compounds that, depending on the history of the patient and the clinical characteristics, you can try. I usually say try them for 3 months, and if in 3 months you don't see a clear response, and you don't tell anything to therapists or to teachers, and you ask teachers, how is Mario doing? How is my son doing? If it's working, they must tell you, oh, he's doing a lot better, you know. If you notice an improvement, if in school they notice an improvement, anything therapy, people notice an improvement, then it's real, you can continue. You can continue, and sometimes I continue for 1 to 2 years. Not more, but 1 to 2 years. If there is no evidence, you're wasting your money, and I'm sure you have better ways of using your money for your child.
Нас було 250 від початку до кінця. Я вам всім дуже дякую. І, Антоніо, тут дуже багато слів подяки до вас про дуже хороший контент, про те, що все це дуже цікаво, важливо і особливо про кейси, які прям конкретні кейси, які ви розглядали разом з глядачами. Ми вам дуже дякуємо за те, що ви приділили ваш час. Це ваш вільний час, вечірні часи для нас. Це для нас дуже цінно. І ми вам дуже-дуже за це дякуємо і сподіваємося, що війна закінчиться і ми побачимо вас в Україні.
As I said, I'm really hopeful, and I want to thank you for staying out with us until late hours. I think my slides will probably be distributed, and there is my email at the end. I do not guarantee that I will respond immediately because I receive too many emails, but if you write Ukraine in the title, I'll do my best to respond as promptly as possible.
Дуже дякуємо всім, хто нас дивився. Дуже дякуємо ще раз, Антоніо. Бажаю всім тихої ночі.